We are in the midst of a COVID-19 pandemic, which is testing the tenacity of all healthcare systems. Fortunately, the disease is mild in majority of children. In the next 20 minutes or so, I will be taking you through some of the key aspects of managing those few unfortunate sick kids who may require PICU care. This talk will cover how to triage and classify severity, what are the indications of PICU admission, what are the indications and options for non-invasive respiratory support, steps in rapid sequence intubation, mechanical ventilation and points to remember, and supportive care and some repurposed treatments. At Triage, first classify children into SARI or non-SARI. SARI is defined as any child with tachypnea and or retractions, nasal flaring with an SpO2 which is less than 94% in room air. These children need to be admitted, tested for SARS-CoV-2 and started on oxygen, empirical antibiotics, decide on ward or ICU care based on response or clinical progression. The severity of COVID-19 infection is primarily classified into mild, moderate, severe and critical. The moderate ones are children who have clinical and radiological features of lower respiratory tract infection. The severe children have refusal to feed, tachypnea or hypoxemia requiring supplemental oxygen. The critical severity is ARDS, shock, multi-organ dysfunction. Of these, the severe and critical require PICU care and will fall within the purview of this talk. The baseline investigations that we need to do in such children is like you do for any other sick child. All baseline organ function parameters are recorded. Important among these are the inflammatory markers which constitute the C-reactive protein, the procalcitonin and ferritin if available, and a coagulation profile. Chest X-ray should be done in all children who need PICU care. Although chest X-ray findings in children are not described in details, findings in adult include consolidation, ground glass opacities involving peripheral lower zones, mostly bilateral. This is what is shown in the representative X-rays that are projected in this slide. CT scan is recommended only if it is going to change the clinical management. The three different phases of COVID progression are as shown in these representative scans, which is early, progressive and developed stage. The blood investigations, important to note, the extent of leukopenia and lymphopenia are less reported in children as compared to adults. Renal function test, liver function test, arterial blood gas analysis should be monitored like for any other sick child. Procalcitonin is more often found to be elevated than CRP in children. Once the laboratory investigations are available, the high-risk cases are those who are clinically symptomatic with leukopenia, lymphopenia, high CRP, procal and abnormal chest X-ray. So, which children will you shift to PICU? Children who fail to improve with supplemental oxygen and have associated shock, encephalopathy and acute kidney injury are candidates for PICU care. Ideally, all these kids must be managed in a negative pressure isolation which has facilities for HEPA filter. In the absence of these, the best alternative would be to have a room area, preferably in the higher floors of the building with exhaust fans, that is creating a negative pressure room. The room should be well equipped for managing critically ill children. All personnel should be in full PPE. The non-invasive respiratory support needs to be escalated in a stepwise fashion based on the clinical status. Start all children who require oxygen on supplemental oxygen with a low flow device like nasal prongs or face mask. Avoid nebulization if possible as it generates aerosols. For those who fail to respond to low flow oxygen therapy, start high flow oxygen, humidified oxygen through either a nasal cannula, especially if the FiO2 requirement is more than 40%. A hood may be used over HFNC to prevent aerosol dissemination. Children who fail to respond to these measures need further escalation to non-invasive ventilation. Adequate interface seal is important when you are giving NIV. NIV is indicated for mild ARDS where the PF ratio is between 200 to 300. Indigenous bubble CPAP can be used if ventilator NIV is unavailable. Remember, aerosol precautions are very important during both HFNC and NIV. Monitor the respiratory status by monitoring the respiratory rate, the work of breathing, the PF ratio, the SF ratio continuously. Children in whom FiO2 requirement is more than 60% with worsening distress and escalating PCO2 require intubation. Intubation, as you all know, is an aerosol generating procedure. So, rapid sequence intubation is very similar to what you do in other sick children, but some of the extra precautions include keeping a plastic hood or a box or a plastic sheet as is shown in the figure. Here, a plastic sheet is being used while giving bag and mask ventilation to a child. Requirement of HME filter or a viral filter if available. Remember, a flow inflating bag like a Bain circuit is better than a self-inflating ambu bag. Ideally, video assisted laryngoscopy and intubation are better if they are available. Intubation must always be done with a full PPE donned with all precautions. The most experienced person of the team should be doing the intubation. The steps are as for any other rapid sequence intubation, except that we use non-rebreathing mask and filter bag assembly for pre-oxygenation. There are important set of precautions that we need to take while we ventilate these children. Attachment of an antiviral filter between the endotracheal tube and the ventilator tubing is a must as is shown in the figure. Use cuffed endotracheal tube to prevent air leaks. Repeated disconnection must be avoided. Hand bagging is strictly avoided. A closed inline suction is the preferred method for suctioning these children. The ventilator strategies for ARDS secondary to COVID-19 follows the same principles as for any other ARDS management. Low tidal volume ventilation, adequate pseudoanalgesia, strict fluid titration 70 to 80% of the maintenance, prevent asynchrony, and a special mention about the need of steroids. Dexamethasone probably is the only therapy which has been proven to be useful in COVID-19 ARDS. All multi-organ support is similar to any other critical illness. Myocarditis, which is seen in COVID-19, can be seen as a part of multisystem inflammatory syndrome, which is described in children, which has overlapping features with toxic shock syndrome and Kawasaki disease. Supportive care which is given to these children is similar to any other sick child who is treated in an ICU. Now, coming to some of the repurposed therapies that you must have often read and heard which have been used in adults. In the early phase of the illness, antivirals can be tried, especially before 4 days. Among the antivirals, remdesivir has shown promise and positive results. In one trial, there was 31% faster recovery and mortality reduction in adults. Trials in children is, however, ongoing. Among the anti-inflammatory agents which are indicated between day 4 to 7 in children who show clinical worsening in the form of worsening multi-organ dysfunction or lab evidence of increasing inflammatory markers which are suggestive of a cytokine storm, we have two options. One is dexamethasone and the other is the IL-6 inhibitor, which is tocilizumab. Both may be considered. Convalescent plasma again in trials has failed to show any conclusive benefits. If planned, it should be given early. Intravenous immunoglobulin is indicated in children who have features suggestive of multisystem inflammatory syndrome. Low molecular weight heparin is indicated between day 4 to day 7 in moderate to severe COVID-19 illness. However, these children should not have any contraindications for the use of heparin. low molecular weight heparin is started at prophylactic doses of 0.5 milligram per kg 12 hourly subcutaneous, especially if the D dimer is more than 2500 or more than 1500 and the trend is rising. Putting all this together, what we need to do is first categorize severity, get baseline investigations, monitor for progression and decide which therapy to give. So, to conclude, COVID-19 is less severe in children, which is a heartening aspect. In the absence of specific targeted evidence based therapy in children, the emphasis is on good supportive care in a PICU setting following all precautions as described. Thank you.